In a way, this talk actually fits in more with patient safety, but it does very much follow on the themes early on about error traps in medicine and actually trying to fix the problem, not the blame. And it relates, if you haven't read Matthew Said's book on black box thinking, I would encourage you to read it. It's very easy read. And there's a quote in it thinking about failure is the very best way to learn. Now, after this morning, we have heard some really quite distressing cases, and it's pretty hard, I think, to think about, to put your hand up and say, actually, all of us sometimes make mistakes, but what I'm trying to encourage you is actually mistakes are an educational nugget that one can learn from. And most of you aren't neurologists, and what I would like you to think about is that all of us as clinicians see errors which happen, and errors which happen repeatedly. What I want to do is use papilledema as a paradigm for mistakes that happen in others. So, think about the gastroenterologist that has a GI bleed and its mismanagement, or the surgeon with abdominal pain where it gets mismanaged. I think all of us have things which we feel very troubled by that keep happening, because that's really what the whole concept of black box thinking is about. In other words, thinking like the airline industry, which kind of relates a little bit to Kevin Stewart's talk later, about how we can learn from error in a balanced way. So, for reasons of time, I'm going to take papilledema as a paradigm, because I'm a neurologist, and also it relates to one of the cases I mentioned earlier. So I want you to all think of something in your specialty that keeps being missed, because I would say that's an educational nugget to learn. So there, for example, is the optic disc, which is swollen, maybe in a patient with a suspected brain tumour. And the reason I got so interested in this was I was involved with a number of serious untoward incidents where it kept happening, where things kept being missed. And we did a lot of work on this, and I would have to say, on the basis of one of the recent convictions, I would have done none of this work, okay, if I was aware of that conviction, because why would I be quite so open? But one of the questions we asked was consultant physicians, what was their expectation of competence? And the 86% of consultant physicians in my trust, not neurologists, felt that competent use of an ophthalmoscope was an essential skill by the time of graduation. So quite a high error, but if I look at this month's clinical medicine, just 2 articles alone mention that only 40% of doctors seeing patients with acute headache would bother using an ophthalmoscope to look in the eye. Another case of the month was a patient with a misdiagnosis of anorexia who had papilledema and cerebellar signs from a brain tumour. So, this is stuff that is being missed on a frequent basis. So don't focus so much on papilledema, but think about the problem in your specialty that bugs you. Okay. What would we do about this? In fact, I wrote a paper on essentially serious untoward incidents that I'd seen where a patient come to harm, so the subarachnoid that gets missed, the posterior circulation that gets missed, but I'm going to focus on the patient that goes blind because they've got papilledema. Okay. And what we did in this study was we actually started asking patients. We did this, a couple of long story short, we looked at 400 patients before, 400 patients afterward. These were patients who got referred to neurology. Just asked them 3 simple questions. Did the doctor seeing you examine you with a tenon hammer T, an ophthalmoscope O, and a stethoscope S, with the stethoscope as the control question? Okay. We did this in 10 hospitals in the UK, a couple in Sweden, a couple in Jordan, and the results basically were crap. Okay. To show you how bad they are, okay, if you have a neurological problem and being seen at Queen's Square National Hospital Neurology, you're more likely to be examined with a stethoscope than with a tenon hammer. Okay. That's how bad things are. Okay. So we were completely open about the data, named all the trusts, which is why I'm saying I wouldn't have done this study based on what happened next, because there are real costs of getting it wrong. When we originally wrote this up, I found one case of missed papilledema where they settled for just over $250,000. Now that's back some years ago. We now know the actual cost is significantly higher. Okay. For example, Honey Rose was the first optometrist that was convicted of gross negligence manslaughter for missing and diagnosed with papilledema. I should say I've got no relationship, medical, legal or otherwise, with any of the cases I'm going to discuss. Now, she got a suspended sentence for 2 years for gross negligence manslaughter. This came out recently, was an article actually from, it is an absolutely tragic case. So Vinnie Barker was a child of 8 who had a routine eye test, who was asymptomatic, okay, so had no symptoms. A papilledema was missed on a digital photograph, and the child dropped dead 5 months later. And then I became aware that that digital image had been taken place, and she was convicted for gross negligence manslaughter for missing that slide. And I think it's a fascinating case. It's obviously there is an appeal going on, so I'm not going to say any more than that. But obviously it leads to lots of media publicity. And at the time, I was very concerned about this because of the work I'd already done on making sure patients are examined. And we had a letter in the Times for over 4,000 healthcare professionals. And I wasn't touting for business, okay, in less than 3 weeks, most of them optometrists. And I'm just going to highlight some of the comments. One particular I'm going to highlight from Hannah Gordon in SBR Medicine. His own father had a delayed diagnosis of brain tumour due to a misdiagnosis of papilledema, because her comments about it actually sum it all up. In 1988, a junior doctor, according to my mother, looked about 22, missed my dad's papilledema during a middle of the night A&E visit. This delayed the diagnosis and treatment of a brain tumour. He died the following year. Now I'm the doctor. I'm incredibly grateful for easily accessible radiology, senior review and ambulatory care to plan easy follow-up. It is changes to systems, not persecution of individuals, that save lives. And that systems and the recognition of system errors is absolutely key for a lot of these cases, and it's something which I think a lot of the expert witnesses fail to address. The other reason I'm mentioning this, in fact, the slides I have quite deliberately redacted, because if we're talking about the issue of grossness, all the information I've got is in the public domain, but I would just ask you your question based on the Honey Rose case. Look at this case, which I became aware of, and this was in October 2014. I won't say where. Woman of 41 who died, admitted to hospital with A&E with headaches and vomiting, working diagnosis of gastroenteritis and dehydration, consultant review, scan not required, reviewed a bit later, seen by a consultant physician, noon, scan not required, let's get the psychiatrist, reviewed again, extensive plantar noted again, at no stage were the eyes examined, urgent CT, worsened, had to have a CT and had acute hydrocephalus from a colloid cyst, and then died. The reason I know about this case and the reason I've redacted it, this was a completely different approach, different coroner, who became aware during the inquest of the TOS study I mentioned about earlier. And as a result of that, issued a Regulation 28 that there are important lessons needed to be learned from this case. The coroner wrote to the GMC, head of the medical schools. Cut a long story short, that's how it ended up being written to me for advice about the case. And obviously someone who develops truly acute hydrocephalus, they may not actually have papilledema, but obviously this is a patient symptomatic. But the trust admitted liability because they hadn't fully examined the patient. So compare and contrast this very different educational approach with the adversarial approach to the Honey Rose case. So the costs, if we look at what of getting it right, well, the cost of a tendon hammer or the cost of a thalmoscope, the cost of a tendon hammer is roughly about 2 coffees at Starbucks. Most junior doctors probably have more coffee than they use a tendon hammer to some extent. And at a thalmoscope, there's a myth that it's very expensive. This is a very cheap ophthalmoscope, costs less than 50 quid. Christmas BMJ works a treat. And also there's a myth that neurologic examination has to be lengthy. We produced an evidence-based examination. If you just Google brief neuro, and it'll come up with a YouTube clip on how to examine the nervous system quickly. You can do it quickly, and all the errors I've just mentioned would be you would pick up if you do it enough. Okay. But the reason I mention this in relation to talk later on about the there's very little talk about patient safety, and I think this is important if we think about the comparisons with the airline industry. You cannot be drunk and a pilot, okay? That breaks the law. Likewise, you cannot be drunk and a surgeon. And so you have to have a rule in the sand about what is legal and what is illegal. But the reason I mention the airline industry is you will all be aware about the Shoreham aircraft disaster, and it was fascinating, the approach. And the reason I say it's fascinating is when the Air Investigation Bureau investigated the black box, investigated the incident, the police wanted the voice box recorder. And the Air Investigation Bureau said, no thanks, you can't have that until we have completed our investigation. It is crucial that we have an independent investigation prior to the police investigation. And my question to all of you, could you ever see the GMC telling the police to get lost while we carry out an investigation? I think not. But I think that independence of the investigation is really important. Now, obviously, there is an ongoing investigation that the pilot may face charges, but it took place after the investigation. I think that is very important. Some mention was mentioned in Dr. Vaughan's talk earlier on about just culture, and there really isn't time to go into this, but what I would say is that just culture is a culture where frontline operators and others are not punished for actions or omissions or decisions taken by them which are commensurate with their experience and training, but where gross negligence, willful violations, and destructive acts are not tolerated. So you can't be a drunk pilot, you can't be a drunk surgeon, but I think one needs to think about the system in which we're working that can lead to errors. So going back to my beginning talk, neurologist joke that neurology NAD means not actually done, okay? So if you think about the patient going blind, just beware the junior doctor assessing them may not have actually done it, may not know how to do it. The consultant in the post-take ward round assumes that it's been done. But I would actually challenge this group, what are they doing about it? Because in fact, when we first did this study, the foundation year curriculum was changed to include the word ophthalmology, okay? And since that's happened, it's been dropped, okay? So in fact, the best defence to a junior doctor who got accused of missing the diagnosis of papilledema is saying it ain't in the curriculum, because it isn't, okay? So I think there is a responsibility to us as educators and regulators to actually, what does the curriculum actually mean? And are we assessing someone at a reasonable level of competence to find that abnormality? So there's a whole issue we could talk about how doctors get assessed. So in summary, what I would say is that error is, despite what we've heard this morning, failure is actually a good way to learn. I've used the example of missed papilledema as a paradigm, but it's important to consider about system errors such as the availability of equipment and cognitive bias. I've just mentioned on the concept of just culture, but it's applicable not just to healthcare, but other industries, the airline industry, even lawyers, and I will stop there.